Good afternoon, everyone. I welcome you all to this post-lunch session of Trendo 2014. I first of all, congratulate the Trendo team for this excellent arrangement for the meeting. Coming to the topic, as you all know, type 2 diabetes is growing up in epidemic proportion in India, and most of the patients with type 2 diabetes will be needing insulin to control their blood sugar at some point or the other. There is also enough evidence now that early control of blood sugar improves the outcome, like reduces the microvascular and macrovascular complication to a great extent later on in their life. It remains a challenge initially to start a patient on insulin, and make them go on insulin, and also it is a difficult task to titrate the dose to get the optimal control. Here we have Dr. Bipin Sethi, who is a consultant endocrinologist in CARE Hospital in Hyderabad. He has done his DM endocrinology from PGH Chandigarh. And this session is going to be a bit interactive session as well. And over to you, Dr. Sethi.
Thank you. Thank you. I'm happy to be with you again. And today's topic is of interest to everyone. And most of us have been in medical college as students or as teachers. And one of the most difficult things for a person is about insulin. So most of the students used to ask us about insulin, how much dose, what to give, when to give. I thought it was nice of Dr. Krishna to have given me this topic, because this is a simple topic and we deal with it every day. Sorry, this is too technical for me. If you press this button, it still doesn't move. So I hope we don't lose the hour in that. Hello? No? Okay. So when we are managing hyperglycemia, we have some core issues. The issues are the target, which have to be taking into consideration the patient's age, his longevity, the drugs that you're using, the problem that the person might be having, pre-existing diseases, social support, and you assign a target for the person. And how are you going to achieve it? By monitoring. And for insulin, it would mean that you have to initiate the patient on insulin, then you have to titrate it to the targets that you set the patients for the patient. And once you achieve one particular target, then you intensify treatment so that you cover not just one, but the entire day's glycemic fluctuations. Obviously, as our seniors have taught us, this is based on diet. The patient has to be educated, he has to be involved, and finally empowered to take a decision. And this is something which is essential for choosing any therapy, much more when it is a therapy which the patient detests, does not want, and wants to postpone till the very end. Why should we be talking about this? Why do we have this delay in initiation of insulin? Because in type 2 diabetics, it is possible to have some degree of control for varying periods of time by stimulating the endogenous insulin secretion or by augmenting the action of available insulin. You have newer and newer agents which are for the patient possible to be administered orally, and people would like to go on and on and on with 1, 2, 3, 4, and if possible drugs for the rest of their life. The second thing is, most people think that insulin is expensive. There is a session going in hall B. Those of you who don't want to listen to me can go to that hall. What is the cost of SGLT2 inhibitors? What is the cost of DPP4? Average cost of DPP4 tablet is 44 rupees. And that is the cost of about 20 to 25 units of the costliest analog that you have in mind. So insulin therapy is not expensive. People are worried about the side effects of the drugs. Sulfonylureas can cause hypoglycemia. Nobody worries about it, nobody talks about it. But when you talk about insulin, people say it causes hypoglycemia. And of course, I said this term because I am very scared of Chennai, except that Krishna lives here and Dr. A.K. Das is nearby to protect me. I said this term trypanophobia, which means fear of needles. I myself suffer from that. If somebody has to draw my blood, my wife has to be there, not the sister, to hold my hand when blood is being drawn. So if in one meeting I was told that, why don't you inject insulin or saline into yourself? I said, why should I? But just to have the feel of it. I said, just to taste the omelette, I should not know how I am baked on the stove. So some people are scared of needles and we have to respect that. The insulin is we have this news of aphasia coming by orally, by administration through lungs, but it's not going to come to our country very soon. All the insulins have to be administered by injections. And we all don't adhere to time, the Indian standard time. We start at this and we are the only two people who came here. I because I have to speak and he dragged me because he used to be chairperson. But we don't respect the time. We say, okay, we'll give this for this many days and after that we will try to upgrade treatment. The patient doesn't turn up. Even if the patient turns up, we turn a blind eye saying that, okay, last time your fasting was 197, today it is 176, there is a trend towards fall, we can postpone it. So it's very funny and the patient will have innumerable number of explanations, you know, sir, this share market, my shares have gone down, my price, this thing, therefore my sugar has gone up, or my daughter is having, either she is not becoming pregnant or she actually became pregnant. All sorts of issues will be there for explaining the poor control. And then we have advisors to the patients. We are the most insignificant advisor to our patient. They have their friends. Then Baba Ramdev comes on a channel for 1 hour saying that all these fellows are useless, whatever they are giving is wrong, what I am telling is the truth. So we don't have just one advisor and we have the patient's advisor. No, don't go to Professor A.K. Das, he will put you on insulin only. There are some insulin fellows, they will give insulin only, don't go to him. And then many young physicians fear that if I start insulin, this fellow is not going to come back. I am a very old person, I am standing in front of you. Once upon a time, I was young. We started insulin, come whatever may. If the patient has to go, let him go. Luckily for me, my next door clinic was my professor, Dr. Shyam Sundar, who is no more. And he used to say, he has told no, you take it. But luckily or unluckily, nowadays you don't have that kind of physicians. They say, that fellow is like that only, you come to me, I will give you this medicine, no matter, it won't get controlled, but still. So we have this case for you, so that you wake up. This is Mr. S, he can be Mr. Sethi, I am Mr. Sethi. Age around 40 years, I am not that. Overweight businessman on optimal lifestyle modification. He is on glimepiride and metformin, his HbA1c is 8.2. Fasting is 150. And postprandial is 240. What do you want to give him? Anybody wants to give him DP4? 1 person, 2 persons, 3 persons, 4 persons, 5 persons, 6, 7, 8. Fine. Anybody wants to give him insulin? Just because the talk is on insulin, please don't put him on insulin. How many people want to put him on insulin? Slightly more number of hands. You people didn't give him lunch, just saying that if you come and don't raise hands, the lunch will be taken away. Anybody wants to give alpha glucosidase inhibitors? Sorry? No, the patient is here only. Fasting 150, PP 240, HbA1c 8.2. Anybody wants to give him glitazones? We are in Chennai. Chennai doesn't believe in glitazones.
No, we are in endocrine conference, not in diabetes conference.
Great, that's very nice. So many few people want to give not do glitazones. Anybody wants to give GLP-1 analog? This patient is obese, overweight, businessman. He is a Chennai businessman. Let's say they always have money. And anybody wants to give GLP-1 analogs? Now after coaxing West. So we have multiple choices. The reason I put these choices out for you is that this patient's HbA1c is 8.2. You give him any active pharmacological agent, the HbA1c is going to come down, but will he reach the target? He is a young person whose target is about 7 if not less, and which of these agents will get him to 7? DPP-4 inhibitors will not, they will reduce by 0.7%. Alpha glucosidase inhibitors will reduce by 0.5 to 0.6. Glucagones will reduce by 0.5 to 0.6. The only contenders are insulin and GLP-1 analogs. The other two cannot reach the patient to the target that you have assigned for him. So you don't want to dent the glucose, you want to get the glucose on the target. Is that all right? So the choice then will be between, we have to give him an injection. You want to give him GLP-1 analog? No problems. You want to give him insulin? No problems. We will discuss this in a greater detail afterwards. Now this is another patient who is having diabetes for about 7 years. She got diabetes at the age of 29. She is on basal insulin already with maximum dose of sulfonylurea and metformin, and now her fasting is 85 to 100. Her cousin came from US saying that you people don't do HbA1c. She said, my doctor never said so, and she got it done. Lo and behold, 7.9. So she is clearly out of control. What are the options for her, and what is the problem? Her fasting is under control. The rest of the time when she is on OADs, those OADs are not getting her to target. The PP sugar is not under control, and the HbA1c is 7.9. You want to give him, what do you want to give her? DPP-4 inhibitor, anybody? Stepwise introduction of prandial insulins, anybody? Please raise hands. Yes? Now you say, no, he started on ADA guidelines, so you want to put him on premix insulin. So anybody wants to shift her on premix insulins? Anybody wants to add GLP-1 analog? So here the issues are of prandial control. As Professor Kannan is here, he is saying that you can add, you have to now control the postprandial sugars and provide the prandial control. What you choose depends on, and nobody will say that for a 36-year-old woman the target is 7.6. No. If anybody is treating her, as somebody said, we are in an endocrine meeting, in an academic meeting, we have to keep the target suitable for her age, 7. And which one will get her to 7? Not DPP-4, either prandial insulin addition or shifting to premix. We will discuss about this, which is not the preferred option, or adding a GLP-1 analog. Now this is a patient which is a little bit contentious, so I think we will just skip this. What are the problems with insulin therapy? Insulin therapy is unphysiological, it doesn't sense the glucose levels. All of us had lunch, and our body knows how much insulin to be produced unless we are a diabetic. Neither will have hypoglycemia, nor will we have hyperglycemia. When we give insulin from outside, it is not possible to sense the amount of glucose that the food is going to deliver to your body. It is not possible. We have a lot of calculations, carbohydrate counting, this, that, but each one is having its fallacies. And there are inter and intra-individual difference in insulin kinetics. We are giving insulin in the subcutaneous tissue and it goes to the systemic circulation first and liver afterwards, and the insulin which is released by our alpha beta cells talks to the alpha cells and tells them to shut down for a moment. So glucagon is not suppressed. So we have the hazards of this situation. You are between the devil and the deep sea. If you do not control, then the devil is hyperglycemia and complications, and if you control very tightly, then you have hypoglycemia, that is the deep sea. For the patient, it could be the other one. So why should we give insulin? How long should we give insulin? How should we give insulin? Which insulin should be given and how much should be given? These are the questions. In most of the talk that we are talking today, we are not talking about type 1 diabetics or gestational diabetes, I am talking of type 2. If the person is significantly symptomatic at diagnosis, whatever be the age, and fasting is more than 250, random more than 300, HbA1c more than 10, there is no question this person has to receive insulin. If he is ketogenic, if he is losing weight, all the more reason. But most of the patients, as I said, can be controlled on OADs for a while. So when OADs fail, are contraindicated because somebody has got hepatic insufficiency, renal insufficiency, pregnancy and you don't tolerate, you are in love with metformin, the moment you give it, the patient has loose motions, cannot digest, then what are you going to give? You have to give him something else. Then the duration for which you give it depends on the indication for which it has been given. This is the secretory pattern which I encourage you to discuss with each patient, that look, your body has to have a 24-hour policing kind of insulin in you, which is basal, and then you have to have prandial surges. Ask yourself, ask your doctor from where these are going to come. And if you have to provide coverage, both these things should be taken care of. If you are giving basal insulin, where is the prandial coming from? Have a self-limiting place. Okay, fine, it will get me the prandial insulin. These are the kinetics of the insulin, which I don't think are necessary for this kind of audience. Everybody knows, but we tell the people that this is what covers the prandial, this is what covers the basal. And the whole idea of any treatment is to mimic this physiological pattern. If this physiological pattern is mimicked, the chances that you have the adverse effects of hypoglycemia and weight gain are going to be minimal. How do you give this? This is the most critical question. Can we give basal? And I ask people to raise hands in the meeting, not because I am talking on a different platform, I will ask separately, how many people start basal? And then people start premix. The split mix is gone because most people are not very clear which insulin to be loaded first. Professor Das is laughing there. If you ask an average medical student, he will not be able to tell you that you have to draw regular first and then NPH, you have to inject the air equal to the amount that you are withdrawing first, prick the needle into NPH, then put the air, then bring it back. This kind of explanation we do not know, we can't tell our patients, so we are not using this, though it is really quite good. And then you have the basal bolus. Devices I am not going to discuss, this is discussed usually by Bansi Shabu, Sushil Jain and all sorts of people. I am not even inclined to do that. So we have to differentiate between insulin initiation and intensification. The initiation part is the most difficult, and this is the picture which speaks 1,000 words. You can choose anything, you can start with one injection, anyway you are going to go to more complex regimens. If you start with premix, the only simplicity of premix is that you have to choose the same injection throughout. That is the only simplicity. Otherwise, it has all the things which are not good for a particular regimen. And as the number of injections increase, the complexity increases. But the basal regimen, because it mimics the physiology, it is the best regimen. And at each step, when you give basal, you are physiological. When you add prandial cover, then you are physiological. Otherwise, you are not physiological with any of these regimens. The basal regimen is endorsed by most guidelines, and one doesn't have to look for a guideline for supporting a particular thing. The problem of premix is that it is always unphysiological. You have more weight gain, you have more hypoglycemia, and if you are on premix, neither can you change your meal composition, nor can you change your meal timing, nor can you change the proportion of insulin that you are giving to the patient. You do a profile, fasting is okay, post breakfast is okay, post lunch is high. You cannot increase the morning dose because he is going to have hypo after breakfast. But if you are on a basal bolus regimen, you can titrate each dose which is looking after that candidate meal. Are these regimens so different? The premix and the basal, are they so different, or are they so similar that you can't spot the difference at all? So there are differences, and that is what I told you. If you look at HbA1c reduction, you have some improvement with biphasic, but if you look at hypoglycemia, clearly it is less with basal. If you look at weight gain, clearly it is less than basal. So if you are looking at a good control without hypoglycemia, without weight gain, then you have to have the basal based strategies. Obviously, when we choose a drug, can we reach the target? Can we reach the target with other fringe benefits like lack of hypoglycemia, lack of weight gain? That is what is important. What can you add if you are choosing basal insulin? You can add prandial insulin. These discussions we have had earlier. And this is what is a proposed diagram wherein they say that once you give basal, if your sugars are not under control, you do the profile and add the prandial insulin to the insulin to the meal that causes highest excursion, and basically convert to basal plus and subsequently plus plus and finally the basal bolus regimen. What are the incretin based therapies and how do they play with insulin? You may say, what is this person doing? Is he trying to please the incretin fellows? No. When you are providing the prandial control, you could use endogenous GLP by giving DP4 inhibitor or exogenously provided by giving GLP-1 analog. Both inherently will not cause hypoglycemia, but with insulin they can. GLP-1 analog based therapies offer advantage of weight loss, but they do have GI side effects and cost is a major issue. Are they rivals? No. Previously we are choosing insulin first, which you can choose one to many shots. There is hypoglycemia and weight gain. Titration is ongoing. You have to go on titrating throughout the lifespan of a person. The cost is very modest. The strong point is insulin has the best experience and monitoring is required more number of times, so you require more SMBC. The plus point with GLP-1 analogs is the weight loss, but the GI side effects is a negative point. Yes, they can be given once daily or once in a week also. There are some studies with combination of this, and all of you must have had clinical experience of reducing the insulin shots, reducing dose, but at an added cost. What medicines can we continue when somebody is on insulin? You can continue metformin. Glitazones cause more weight loss, weight gain. If they are given with insulin, they are preferably avoided. If your control is dependent on sulfonylureas for prandial control, with basal insulin you can very well continue your sulfonylureas. You can continue DP4, you can continue metformin, and you can, as we said, put this, and you can also add alpha glucosidase inhibitor, for that matter even SGLT2, because they are having a additive mechanism which does not depend upon endogenous or exogenous insulin supplementation. Again we have some problem here. Now once we have chosen a dose, how do you titrate it? This is a diagram which was taken from Rosenfeld, the first study that they did for treat to target. They said, okay, choose the numbers, and based on that choose the number. I encourage you not to look at this, because what is coming is this, the Atlanta study, wherein they asked the physicians to titrate according to Rosenfeld and the patients to increase the dose by 2 units whatever the level of sugar. Can you believe that at the end of the study both the titrations had the same HbA1c target? So what is a great deal? If you ask me to tell what the numbers are there, I cannot tell you. So I tell my patient, do your fasting, less than 80 decrease by 2 units, more than 100 increase by 2 units, 80 to 100 continue. Simple. No, if it is more than 180 you increase by 8 units, 140 to 120, how much was that? So ask for 2 units. If you are so scared, ask for 1 unit, but please titrate. You cannot choose a dose and cannot stay there. For premix insulin also again the same numbers are there, but I again encourage you to tell the people to just increase by 2 units. This is the ADA target which I have shown you earlier. So you start the prandial insulin with the highest excursion and then go on adding the insulin based on your requirements. Earlier insulin therapy, this was very popular topic earlier. Usually we initiate insulin when the OADs have failed. But if insulin is initiated at a time when other therapies could have also worked, that is called early insulin therapy. This particular therapy has been often successful at diagnosis because you preserve beta cell mass and try to postpone insulin. But what are you postponing? What you are giving right now. So the patient might not have any liking for this particular regimen. Most physicians give it to absolutely symptomatic patients. They don't give it with the intention of preserving the beta cell mass. There are some proponents, and this is some topic which can be debated for another 2 hours, but I feel that do not delay insulin therapy when it is absolutely necessary. What are the problems? Which type of insulin now? Are you going to give conventional or are you going to give analog? Conventional insulin, the delayed peak of short acting insulins is really not good to make them cover the meal. They have spillover action beyond the meal. So they don't work when they have to, and they're working when they shouldn't be around. The longer acting insulins, they tend to peak and they do not cover 24 hours duration. The analogs can be produced by modification of amino acids, or you can do a structural modification with or without a fatty acid spacer. The advantages of rapid acting analogs are flexibility, lesser hypoglycemia, lesser weight gain, and one of the analogs can even produce weight loss, and lesser inter and intra individual variations. But for basal analogs, this advantage is clearly demonstrated. For the prandial analog, the Cochrane review says that apart from flexibility, the rapid acting analogs do not have really much to offer. The disadvantages are that, as I said, there is lack of long term data on clear superiority, they are costly, availability is a problem, and certain insulin analogs are available only as disposable pens, which is a problem to the patient because it increases the cost to that particular patient, and some of them are not available in vials. This is the most important thing. I think you know this person, he is not from Chennai. He is Domicilis, who told the king that your life is so beautiful, all the time you have got girls at your disposal, they give you wine, you can do anything. And the king told him, okay fine, you sit on my throne, and he hung a sword which is balanced by a single hair from the horse's tail. And he said, enjoy. This person is looking at the sword, not looking at what is being offered to him. So hypoglycemia is that kind of fear which is in the mind of every patient. You are telling him, I will prevent diabetic complications, I will see that you have this and you have that. He is worried about this sword. So all our patients are living with this particular fear, and this is really important. Ask any patient. Many patients tell that hypoglycemia to them is more dangerous than nephropathy, than loss of life or limb. You ask yourself, the moment your patient is on anything other than metformin, DPP-4 alpha glucosidase inhibitor, GLP-1 analog, and he rings you up saying that, sir, I am feeling a little dizzy, then what do you tell him? Eat something. It may not be hypo also, but still you are worried. Guidelines have been created on that, and it is always factored when you choose an agent. When we choose longer acting analogs over NPH, we are choosing it only for hypoglycemia. When we choose DPP-4, sorry, this is a mistake for me, by me. GP4 inhibitors, SGLT2, you always choose them over SUs because they don't cause hypoglycemia. Hypoglycemia leads to dose omissions, dose reductions, admissions, and one admission in any of the corporate hospitals, not only in Chennai but also in Hyderabad, can cost 5 years treatment by insulin and monitoring. So we have to avoid this. People start doing defensive SMBGs, they have never done blood sugar, but he will have 6 blood sugar done in 30 minutes time. Some people feel that this might increase the CV event and might even cause mortality. Then we come to the key issue before you ask me that question, is that are the hypoglycemic events less with glargine compared to NPH? Yes, they are. Are the hypoglycemic events with degludec less with glargine? There is some controversy. The problem is the data is not consistent across the board. As in all trials it is not demonstrated. I will show you. The cutoffs used for hypoglycemia by the degludec studies was a blood sugar of 56, which is not the ADA definition for hypoglycemia. They looked at the timing between 12 o'clock to 6 o'clock, whereas the timing is about 12 to 8. If you extend that, then you definitely increase the incidence in both the arms, and this particular thing disappears. Curiously, this difference was not seen in United States and Canada. Same molecule, same region. This is the data that is shown by the confirmed trials, which says that this is the overall. You look at this, always we look at, is it crossing 1? There is a tendency for degludec to look better, but it is crossing the line of unity. And you change the time by 2 hours. Where is the number here now? At the dot line. Fine. This is nocturnal hypo. Then you say confirmed hypoglycemia clearly looks better with a degludec, but you change the timing at those 2 hours and that is erased. This is published information by David Owen, who has clearly studied this data much more than you or me might have had the time to do so. So, the general impressions about basal insulins are basal insulin does not work. If you ask a medical student to start insulin for a patient who is admitted in the ward, he will say 5 units of rapid acting, short acting, 555, doesn't get controlled, 888, 12, 12, 12, when the time is there, when the round comes next week, the patient has to be discharged. And then he looks at the PG, the house surgeon looks at PG, says, what shall I write? Oh, you write something, man, we need the bed. And that is where we are stuck, because we never use basal insulin. Basal insulin is not safe. People think it is carcinogenic. There were elegant studies published in Diabetologia 3 years ago. It is not safe for the heart. And then the question is, which basal insulin is better? So let us not get into this story. So some of these doubts, I hope, will be cleared at the end of this talk. But they do work. Our medical relic is that same regimens we use, we get same results. I never discharge a patient with control in my medical college. It can be used in acute settings also. You can use in rapid, there's evidence with one basal analog, but others also exist. And there are the guidelines. Compared to other regimens, people feel that it brought the patients to target compared to the premix regimens. And if you use only one study, you may prove or disprove one point, but if you use the meta-analysis, which I showed you the numbers of, clearly there is a tendency towards lesser hypoglycemias and lesser weight gain. Carcinogenicity, people said it causes cancer because of cross-reactivity of IGF-1 receptor, not realizing that there could be methodological problems in the analysis and the results were inconsistent across the trials. The final nail in the coffin of carcinogenicity, CV safety were laid down by this study, which has been shown earlier to you, that any cancer death was the same as that of placebo if you use glargine for 6.2 years in more than 10,000 patients. And lesser number of patients were there on metformin in the standard, in the intensive arm. So this, if anything, the standard care people should have had lesser malignancies because they were on metformin. So despite lesser metformin, people in the glargine arm had the same degree of cancers. You know that metformin, some people believe is less carcinogenic. So the other issues are there, that whatever the choice, you may choose any insulin, any brand, the provision of prandial needs should be factored for most meals. If you use a premix insulin, you are not covering the lunch so well. How are you covering the lunch? You should ask that question. Issues of weight gain and hypoglycemia need to be addressed. Premixed regimens provide upgrading with the same insulin when juggled with numbers of shots and sugars, but they are inflexible and produce more weight gain and hypos, exactly opposite with basal insulin. So in conclusion, we have individualized care. We must do that. I said in the morning, and I will not change my stand just because I am talking for something else. I believe in it. Most guidelines suggest that initiation with basal or premix insulin, but though people reach target, you have quality of life issues which are clearly better with basal insulin. Whatever the regimen that you decide is determined how you mimic the normal secretory pattern, and finally you have to ask the patient what he wants. There are patients in our clinic who are offered basal who would not take it. But we can't say that you don't have to, we won't give you insulin. There is another patient who says that, oh, I didn't know this, let's start. So you have to put him into the loop. And while early insulin may provide some kind of beta cell rest, it is not really having issues, it's not without issues. Clinical inertia remains a major barrier to insulin initiation and may impact patient outcomes. With that, I'll stop here and then encourage you to ask me questions. Thank you very much.
What about bedtime insulin?
Sorry?
Bedtime insulin.
I'm sorry, I'm pioglitazone addition hypothetically improves the insulin sensitivity, but the greatest weight gain greatest incidence of heart failure occurs with pioglitazone. So therefore, people would not like to give pioglitazone in combination with insulin. And sir, you were saying something.
Thank you, Dr. Sethi, for
So there is somebody who asked another question there.
Yeah, he's going into
So he is not the person.
No, that person.
Yes.
Yes.
What about bedtime insulin?
Yes, the basal insulins are usually given at bedtime. Usually it is a analog insulin which does not peak, controls the fasting very well, and if you have got OADs in place which are controlling your prandial excursions, it might work for a couple of months or even 1 or 2 years. It is the thing that has to be done for using basal insulin, though longer acting insulins can be injected at any point of time in a day.
Now, I would like to add one point regarding your communication with the patients,
Yes.
particularly by our young colleagues. Now, they need not have any hesitation in initiating the insulin and the resistance from the patient side. You casually mentioned they will go from you to another person, another physician.
No, I am not afraid of that.
No, I want to make it clear. I have been practicing diabetology more than 30 years, and not even a single time I have failed in convincing the patient the need for taking insulin. The only thing is that I spend more time with him explaining. That aspect, if you can do that, and if that skill you develop, you need not have the fear of as if you are forcing the patient and he will migrate from you to another person.
Thank you very much. You are echoing my thoughts.
There is your David Owen's hypoglycemia. Those data are from type 1 or both?
They are both for type 1 and type 2. I am telling you about the overall published results from those studies. In type 1, actually, by some kind of a trial design, there was higher incidence of hypos in degludec, but that is technical. I am not saying that it produces more hypoglycemia. I never said that.
No, just to clarify, the
whole
idea of that degludec is that
is an
the
overall.
best, you know, so much is spent for type 1 diabetes.
Yes.
So as far as we are concerned, in our country, there is no room for that degludec, theoretically as well as in practically. Now the good news is that glargine, the patent is going to expire. So glargine will be available freely and cheaply. So we have to exploit glargine and shouldn't allow the room for degludec. There is no role for degludec. Centuries ago, this company was exploiting us because they had one another long-acting insulin, Detrimer. So they could motivate even this Jipmer professor. They all will talk that this causes weight loss, but till as nothing has been proven. So make sure that at least in your endocrinology platform, you don't promote that degludec. In India, we don't need that degludec. We'll wait until the patent expires. The hypoglycemia and all is only for type 1. I don't know. At least that thanks for allowing me to express. This is proven.
I am so happy that you said something, but let's not be against companies and individuals.
The company asked us to give I will give an opportunity to rebuttal. See, they talk openly that you promote Detrimer. See, Detrimer hasn't got a long time. They all will teach. They have been paid. So these people, they pollute and they degrade your organization. At least future you change.
No,
ask him.
Okay, no, please. I think this.
So that is how they degraded the department.
Thank you, sir. Your point well taken.
Thank you.
Actually, the thing is there are advantages and disadvantages in both insulins.
We are happy. See,
we can't say
as a mass
this is
they
first
promote.
insulin.
That is why they have.
Sir, your point is
okay. Your
taken.
point is taken.
Yes,
Thank
sir.
you.
See, diabetology is a patient-centered care.
Exactly. Yeah.
Now he is setting that, telling my previous question I was telling, he has convinced the patient about initiation of insulin and he got his results. My question is, how to convince the patient?
Yeah,
I don't think it is an easy job.
No, it is. I agree with you. But let me tell you one thing. What my professor
Can I
taught.
add something, sir?
Yes, please.
How I convince my patient. I
would
completely
be very
agree with
nice.
him. By convincing the patient, you can make the patient to take insulin. Though not on the first intervention, probably at least the second visit or third visit. So I used to tell my patients, say diabetology, diabetes is not a curable disease. It is a preventable disease. Primary prevention, secondary prevention, tertiary care. Now, you have come to the disease, you have got a disease which cannot be cured. But all the complications can be prevented. Now, you tell me, another 10 or 12 years, now you got diabetes for the past 6 months, now you make a diagnosis, and you need insulin because very high. And you are going to develop the complications, not now, after 12 years or 15 years. Now you tell me whether you are agreeing, going for the complication of 12 years, or you want to prevent the complications. If you want to prevent, now it is a time for you to take insulin. Probably I may withdraw after some time, depending upon your response. But now, right now, ideal for, suppose I am in your position, I will take insulin. So what do you say now? Ultimately, you are the decision maker. But as my duty, I have to put the facts to you. What do you say now? See, when I say this, almost 98% of the patients, they agree, they take insulin, and after some time, I have to withdraw, especially when I start insulin early, as an early intervention. I'll be, because of the episode, I withdraw insulin and go in with the oral drugs also. So this is my experience, just I want to share.
Yeah,
thank you, sir.
Thank you.
Thank you, sir. In fact, my professor used to tell, it takes 15 seconds, I will tell you. You have a disease which is because of insulin deficiency. The drugs that I am going to give you are going to work through the insulin that your body must make. A day will come when these won't work and you will need insulin. 10 seconds. And some of the patients come after 5 years saying that, sir, you remember that day? You told me now the day has come, give it to me. So the resistance of the patient is less if he knows the disease process. So I think you have a very valid point. The second point I have is, do not send the patient to X, Y, Z for learning insulin. Give it in your own clinic, with your own hand or with your nurse's hand, whichever is more delicate, and the patient will know that it is not as painful. If you tell him that no, you contact Subaya, Chinnaya, Tilmaya, then that Subaya, Tilmaya will never reach their house. So tell him to take it there, then in front of you, and then the compliance will be better. This is some of my mistake. I will give the mic to the chairperson.
Sir, I may be permitted to add one more point. For decades we have been practicing diabetology in this city. 20 years back, it is only disposing the patient. We never spent time for patient education. We have depended upon exercise, food, drug and insulin. They were only 4 legs of a table. We never attempted to make it the top. So when our colleagues abroad have organized patient education program and diabetic nurses and all, we were not doing that. Now we are facing the brunt of the problem. All complications are coming up to us, taking out crores of rupees from the government exchequer in the government hospitals, in even in private sector. So what I am telling, this concept of difficulty in explaining and communication is not really difficult. Now you must develop the talent. For example, if I want to start insulin, I will tell only one word. Imagine you are going in a horse. If the horse is not running properly, what do? You give a one hit. If you go on hitting, what will happen? It will lie down. On the other hand, you give rest to the horse for some time, give it some water and other things, that will run fast. Like that your pancreas is getting exhausted, there is no point you are going on adding on the oral drugs which acts only by stimulating and secreting insulin. Better you take for a short time. Like that, we must develop the talent if you want to practice diabetology. Probably that is why from endocrinology, diabetes has migrated to the diabetologist.
Okay, sir.
I beg to differ, but
There's
it's okay.
one other question which I would like to ask you, sir. In many meetings, they raise this question. For initiating insulin, and many in diabetes centers as well, they do this. For initiating insulin, is C-peptide in any way, measurement in any way useful?
I think you have a point, but it's a bioassay. When the patient's sugars are clearly not controlled with whatever you have done, whatever medication the patient could afford and take, and still is uncontrolled, we have to go on to insulin. And for that, you don't require a laboratory, you require clinical science, and patient is telling you. And the target, let's say your clinic's target is fasting 100, postprandial is 150. If the fasting of the person is consistently 150 with all the things that he can swallow, chew, insert, what are you going to give him? You give him insulin. There is no point in telling your C-peptide is 0.67. That's the additional tool, and I agree with the people who have said that it depends on how you communicate. If your communication is so weak that you depend on technology to show it to them, by all means do C-peptide. We don't do it, and I don't regret it.
Just to add up, see, so much developments is happening in the insulin arena, that nasal insulin is coming up.
Which one?
Nasal insulin.
It's actually the inhaled insulin. Which
inhaled,
a phrase. Okay.
And one another thing is that oral insulin. So there is a company, Oromed, in Israel. They are coming up with, and the Novo is willing to, hopefully one day they will come into it, because David Golia, this very small company, Novo don't want them to market, they might buy and come back with the oral insulin. So hey, happy days are here again. Let's see, we'll wait, and at that time we will get all this basal insulin cheaper and much better. That's what I think.
You will still need a basal insulin shot.
Yes. Because we don't know how long this will work, oral insulin or nasal. But again, these are all the modalities which might be available in the market soon.
Yeah.
Okay. If there is no other questions, we will end this session. Now it's time.
Thank you very
Thank you,
much.
sir,
Sir, 1 minute.
for your excellent presentation.
See, in my practice I have seen initiating insulin early or when it is required, his problem is not entirely depending on the patient. It is the delay is partly because of the doctor's inertia. And if you convince the patient and educate the patient, a well-educated patient, they say educating the patient is not one of the treatment, it is the treatment. You have to educate him, tell him about the complications. Then we have seen many times the patients are willing to take insulin. And now with the devices available with pens and all, even though they are expensive, it is very convenient for many of them to take.
Thank
That
you.
is why we ask the younger generation to work in a diabetic
Thank
ward,
you,
not
sir.
merely to get diplomas and degrees somewhere and call you. Only when
Sir,
you
thank
work
you,
somewhere.
sir. We are going to
Yeah.
close the session. Thank you.